And that was not planned. And I actually was very excited at the end when I realized all four were females, because it means more women are in the sciences today, including our journalist. Our first speaker this evening is Maren McKenna, a senior fellow in health narratives and communication at the Emory University Center for Study of Human Health, and is an acclaimed author, as you can see from the slide, and she specializes in public health, global health, and food policy. She has been or is a contributing editor at Scientific American and has written for numerous publications, including but not limited to the New York Times Magazine, the New Republic, the National Geographic, Newsweek, NPR, and the Smithsonian. As you can see from the slide, she's also the author of 3 award-winning books. One was The Big Chicken, the incredible story of how antibiotics created modern agriculture and changed the whole way the world eats. She has also written Superbug and Beating Back the Devil. You can also see from the slide that she's won numerous awards for her leadership and communication skills in scientific writing and speaking on the topic of antibiotic resistance. I honestly believe she writes faster than I can read. In addition to her writing, she has appeared in documentaries such as by Netflix and Vox Media. And as you can tell from the slide, that she did a TED Talk in 2015, which has been viewed by more than 2 million times. At Emory, she does find to teach. Time to teach. At Emory, she teaches classes in writing and podcasting, gives workshops in narrative strategy and storytelling, and presents the Health Storytelling Author, which is a Q&A series of interviews with prominent authors who have written new health-related books. So she does Q&A sessions with them. As you can imagine, we are most fortunate that she was available to speak with us this evening. Our next speaker we're also fortunate to have Dr. Majad Al-Subani, who prefers to be called Subani. Her clinical and expertise and research in infections, in immunocompromised hosts, her antimicrobial stewardship, and general infectious diseases research has undoubtedly contributed probably to Maren's ability to communicate about them. Dr. Al-Subani is Director of Antimicrobial Stewardship and attending physician at Tufts Medical Center and Assistant Professor of Medicine, Tufts University School of Medicine. She did fellowships in infectious disease and transplant infectious disease at Tufts Medical. And while in her fellowship, she used her spare time to earn a master's degree in clinical and translational science, also at Tufts. She's board certified in both internal medicine and infectious diseases. As it states on the slide, her clinical interests include antimicrobial stewardship, diagnostic stewardship, infections in immunocompromised hosts, and general infectious diseases, all of which bring her here this evening. Our third speaker is Dr. Mary Lou Manning, a fellow, and I mentioned this first, she's a fellow in the American Academy of Nursing. She is a professor at Thomas Jefferson University, where she serves as director, Center for Infection Prevention and Antibiotic Stewardship, and senior associates to the dean for strategic initiatives. And she also teaches. She brings 47 years. She's probably going to kill me for that. She's taught has been experiencing in nursing since for 47 years. And over 47 years, she developed research and clinical interests in infection prevention and control, antibiotic resistance, antibiotic stewardship, nursing leadership, and curriculum design and evaluation. in nursing education. She has numerous publications like our other speakers, including many of which are relevant to tonight's topic, one of which was the urgent need for nurse practitioners to slow antibiotic resistance and advance health equity through appropriate antibiotic prescribing. In the past 5 years, she's been principal investigator or co-investigator for 6 funded research projects. And as you can see, she has numerous awards that she has received from various associations, as well as from Thomas Jefferson University. She has been recognized as a hero in implementation research and as a distinguished scientist and distinguished teacher. She's an advanced practice infection preventist fellow in the Association for Professional Infection Control and Epidemiology and a fellow in the Society for Healthcare Epidemiology of America. Like our other speakers, we are really lucky to have her here this evening. And our last speaker is Dr. Megan Davis. She's an associate professor at Johns Hopkins University. She's educated as a veterinarian and has her MPH and PhD in public health. So she brings a very unique perspective. She currently studies the interface of bacteria and hosts to reduce microbe-mediated diseases in people and animals. As you would expect, her research interests include antimicrobial resistance, her asthma, environmental epidemiology, molecular microbiology, microbial ecology, and the microbiome. But she also focuses on veterinary medicine and One Health. And I did not know what One Health is, but according to the CDC, One Health is an approach that recognizes that the health of people is closely connected to the health of animals and our shared environment. She too has won awards and is well published. And here I do want to read this in closing on the introductions. Here's how she describes herself. As a molecular epidemiologist and environmental microbiologist, now I'm going to have trouble getting this paper. Study the interface of bacteria and hosts to reduce microbe-mediated disease in human and animals. My work applies the principles of One Health and microbial ecology, evaluating target microbes and bacterial genes specifically, and the larger microbial community or microbiome. Designing and testing interventions to combat the rise of bacterial antimicrobial resistance and both infection and non-infection outcomes related to microbial exposures in a One Health context is the goal of her research career. So I do want to close by saying I did my best to shorten these introductions, but our speakers are so gifted and have accomplished so much that it was difficult to do. So, Maren, I now turn the evening over to you. I'll stop sharing my screen.
Thank you so much for that introduction. I am really pleased to be invited to do this with these incredibly distinguished scientists. And it is a great thrill that this is an entirely female panel. That makes me extremely happy. So thank you so much for the invitation to speak. Let me get my slides started. Okay. So as you heard, all of you who are here, thank you so much for coming. I am a journalist and author, and my research focuses on the emergence of antibiotic resistance and the stories we make around antibiotic resistance. So I understand my role here to be launching us into a discussion of AMR by reminding us of the history behind it. So, as a writer, I am obsessed with stories. Making stories is how we humans record our experience, how we share knowledge, how we learn. That's been true since our prehistory. And in our struggle with antibiotic resistance, I see the echo of an iconic story, the tragic hero brought down by a careless flaw. With regard to antibiotics, our tragic flaw is carelessness. We failed to give antibiotics the respect they deserved. We assumed they would always be there. We gave no thought to the consequences of using them in the ways that we do. And by doing that, we put their power in peril. And the reason this feels to me like a classic tragedy is that in a tragedy, the protagonist is warned by another character, by the literal Greek chorus, that they are making a mistake. And over the decades, we had many warnings that the way we behaved with antibiotics would cause us to risk losing them. I hope this situation is like a classic tragedy in one other way. In all the great dramas, there's a moment when the protagonist is allowed a chance to think and possibly to change their path. And it feels to me that we are at such a moment now with regard to antimicrobial resistance. I'm going to use the acronym AMR. After the shock of the COVID pandemic, health authorities and partners are adopting the language of pandemic to try to bring to public attention how very serious, in fact, increasingly dire, antibiotic resistance has become. And this phrasing has become very common. You can see a few instances here. I don't know whether it will be successful because the history of the COVID pandemic itself is becoming so contested. But I take it as a signal that health authorities recognize the gravity of the moment. And I think that attempt at communicating an emergency is justified because for antibiotic resistance, the news just keeps getting worse. In fact, the events of COVID that brought forth this silent pandemic language, especially in the earliest years of the COVID pandemic, actually accelerated the problem of AMR because before there were vaccines, COVID put people into ICUs at astonishing rates. And in those ICUs, patients received multiple courses of antibiotics to protect them from secondary infections. And at the same time, because of the burden of COVID, hospital infection prevention necessarily fell off as a priority beyond dealing with absenteeism and saving people's lives. So well-known numbers for the incidence of AMR published before the COVID.
Maren?
Yes.
Excuse me 1 second. Are you aware that your notes are on the screen in front of your slides?
I am not. That's so funny. Thank you so much. I thought I had only shared my slides, but I appreciate you telling me that.
Yeah, now you just have a slide up here, which is the WHO World Health Organization warns of widespread resistance.
So that's very strange. Well, now you all know my secrets, which is that I write a script. But let me see what happened. Let me try again.
How well you know that script.
Okay, so that should be. Can you see my script again?
Yep.
I've never had this happen before. Okay. Well, I'm not going to subject you all to my script. So give me just a sec and I will fix this. And that way what I say will be surprises to all of you.
Okay.
I'll put it on another screen.
Yep, no problem. It really isn't. We won't take this away from your 20 minutes.
Everybody talk amongst yourselves.
I'm very excited about the number of people that are here tonight, and excited about the particular panel because, like I said, the speakers have just done so much and accomplished so much. And we're just lucky that they were all able to share it tonight.
I use that same setup for teaching my remote classes, and I have never seen that happen before.
Well, look at me. I did all my wonderful polls, and I've never seen it happen before where I lose them out of nowhere.
Okay, here we go again. So
Okay.
thanks, thanks everybody
Right.
for being so, for being so tolerant of my low tech, despite the fact that I taught like twice today, taught classes twice today, something obviously went wrong. So as I was saying, formerly well-known numbers for the incidence of AMR that were published before the COVID pandemic pretty quickly became out of date during it. The newest ones, which were published this year, in fact, just last month, are really alarming. As you can see in this WHO press release announcing a report they published just last month, 1 in 6 bacterial infections worldwide now possess significant resistance. And here's what those infections look like, broken down by region across all bacterial pathogens combined. From the lowest in the Western Pacific region, 1 in 10 infections being resistant, 2 in Southeast Asia, 1 in 3. That's a striking and troubling amount of antibiotic resistance. And it results in a striking and terrifying set of numbers for mortality and morbidity. It's just mortality that's here on my screen. As the slide says, abstracting an influential report in The Lancet that was published earlier this year from a team that has been studying and predicting the toll of antibiotic resistance for a while. There are almost 5 million deaths per year right now, between deaths for which AMR is directly responsible and those in which it is a fatal complication. And by the year 2050, the prediction is that from 5 million, the total will be 9 million. The US numbers that parallel those were collected a few years before, but they're equally worrying. Almost 50,000 deaths per year and almost 3 million infections. That's according to numbers calculated by the Centers for Disease Control and Prevention. So it's reasonable to ask, how did we get here? The answer is biologically simple, but socially, politically, programmatically complex. Resistance, of course, is simply bacteria's response to our deployment of antibiotics against them, which is a very reasonable response, given that most of our antibiotics are based on compounds that bacteria develop to defend themselves against attack from other organisms. Simply, they defend and they learn. The strong, or the randomly better equipped by evolution, survive and multiply into the living space that the weaker ones left behind when they were killed. And having once emerged, they find their profitable niche, whether that's the skin of a patient vulnerable to MRSA, or the hospital surfaces where Candida auris can find a home, or the guts of production animals given antibiotics to protect them against the effects of crowding in feedlots. There's something that I think almost all of us forget, which is that antibiotics are a pretty recent arrival in human history. The antibiotic era begins, depending on when you start counting, either in 1928, when Alexander Fleming first recognizes the action of penicillin on a laboratory dish, or in 1941, when the drug he develops is given to a human for the first time. So the antibiotic era at its oldest is 97 years old. That's one very long lifetime. For us, antibiotics have always been there. We have no sense of how extraordinary and precious they are because we've never experienced life without them. We've forgotten what earlier generations knew, that, in the time of my great-grandparents, life without antibiotics, which is to say, without guaranteed protection from the ravages of infection, is always uncertain and often tragic. In my own grandparents' lifetimes, surgery and childbirth and accidents routinely were fatal. My great uncle, a New York City fireman, died of a resistant infection in 1938, not from a fire, but from being scraped by a piece of equipment at his firehouse in Manhattan. So equally dangerous were random injuries and childhood illnesses, and as this 1930 magazine ad shows, something as simple as cutting yourself while shaving. This is an ad for Listerine, which we think of now mostly as a mouthwash, but it was developed as a topical antiseptic. And the suggestion of this ad is if you do not use Listerine before you shave yourself with a straight razor, because safety razors had not yet been invented, you may intend to look like the chap on the left going out for the evening, but you will end up like the chap on the right in the 1930s equivalent of an ICU. So penicillin, which is the first antibiotic, changes all that. When it arrived, it rolled out across the battlefields of World War II in 1943. It was an absolute sensation. Because of that new drug, hundreds and thousands of soldiers and sailors survived the war who would not otherwise have come home. When it was made available to civilians a year later, people who would have died terrible lingering deaths from infection were saved in days. Sometimes it seemed in hours. There was a reason why they called them the miracle drugs. At the time, penicillin was not prescription only. It was an over-the-counter drug, at least not in the United States. And until the early 1950s, it remained over-the-counter, and it took off in the market like a rocket. There does not seem to have been any thought to any downside for how rapidly it was being deployed, even though among the earliest patients in trials, there had been signs that the wonder drug could lose its effectiveness surprisingly fast. And one who saw that danger was its parent, its developer, Sir Alexander Fleming. He very memorably warned in his acceptance speech for the Nobel Prize in Medicine in 1945, which was given for the development of penicillin to himself and his collaborators. He warned that the potency of these wonder drugs was already being put in peril by the relentlessness of bacterial evolution and the carelessness of users. This is what he said: the time may come when penicillin can be bought by anyone, which was already happening, and the ignorant man may underdose himself and expose his microbes and make them resistant. And he was absolutely right. By 1947, penicillin-resistant staph, which was a thing that had never before existed in the world, began sweeping the globe. It emerged first in hospitals in London, then that was in 1947. It landed in Australia in 1953, or perhaps convergently evolved. It arrived here in the United States on the West Coast in 1955. It caused a massive outbreak in the labor and delivery unit of Harborview Medical Center in Seattle, which was then and remains still the chief safety net hospital in Seattle. There were 1,300 brand new mothers and 4,000 babies infected in that outbreak, and 24 of the neonates died. By 1957, 12 years after Fleming uttered this warning, resistance was advancing so fast that the American Medical Association staged a summit meeting at Case Western Reserve. I've read the minutes, and there is a very clear sense of panic that they cannot understand how the golden era of the miracle drugs is ending so rapidly. So what came from that worldwide panic was first a new drug, which was originally called Celbenin and came down to us as methicillin, the first of the semi-synthetic penicillins. And this is the first ad that its developers, Beecham Laboratories, ran in January 1960 in a British medical journal under its experimental name. You can see they boast effective against all resistant staphylococci. Because I've trimmed the ad, you cannot see what they say further down the page. It was a full page ad. It went on to say, resistance unlikely to develop. And they were right on the drug's effectiveness against penicillin-resistant staph. They were a little wrong on how long its effectiveness would last, because within a year, methicillin-resistant staph, what we know as MRSA, was identified in a hospital in London. But what also came from penicillin-resistant staph and the deployment of methicillin and the advent of methicillin resistance was the beginning of a sort of game of leapfrog of between bug and drug that we embarked on without really ever admitting that the game was stacked against us because the bugs had evolution on their side. What we'd done with penicillin, without thinking deeply about it, was to take the weapons that bacteria made to deploy against each other, the products of millions of years of evolution, and use them as though they were an inexhaustible resource. And by bathing the microbial world in antibiotics, we accelerated the development of resistance. And we used up those naturally derived compounds whose activity against bacteria had seemed so miraculous. Of course, by 1960, when this ad ran, there were other antibiotics already on the market: chloramphenicol, streptomycin, and erythromycin, the first of the tetracyclines, the first of the cephalosporins. Each of them lost their power in turn. Here's just a few examples. Vancomycin, which was a last resort drug that was used when methicillin and its relatives failed, came into wide use in 1972, and vancomycin resistance arrived in 1988. Imipenem, the first of the carbapenem class, was released in 1985, and resistance to it arrived in 1998. Daptomycin, intended to replace vancomycin as it failed, came on the market in 2003, and resistance to it was recognized just 1 year later, in 2004. I think it really, as I look back, it really took until about the 2000s for the warnings about antibiotic resistance to get really loud and to begin to be taken seriously. And one of the health authorities who has been most prescient about this is Dame Dr. Sally Davies, who's now the Master of Trinity College at Cambridge University, but was the Chief Medical Officer of the United Kingdom. And in 2013, in that role as the Chief Medical Officer, she published this warning of the global risk of AMR, calling it as serious as climate change or terrorism. So I want to remind us of the breadth of this accelerated emergence of resistance. The discovery of MRSA forced the increased deployment of vancomycin, and that led to the emergence of vancomycin-resistant enterococci, VRE, in hospitals in the late 1980s. Triggering panic, but also, if you remember, for those of you who were working then, triggering fresh attention to hand hygiene as well. With that niche of skin attended to, pathogens found a fresh one of inorganic surfaces, and that leads to the development and emergence of carbapenem-resistant Enterobacteriaceae, CREs, which in the 2000s made a home on those cold inorganic surfaces, forcing a reevaluation of hospital hygiene and housekeeping and janitorial services, making them partners in the infection prevention enterprise. But at the same time, highly resistant bacteria were learning to thrive in the rough and tumble of the everyday world. For more than 20 years, formerly conquered community infections such as gonorrhea have been quietly developing defenses that render them close to untreatable with current drug options, taking that STD out of the category of infections that can be cured with quick oral dosing in community care. So I want to say that it's important that the deployment of antibiotics in healthcare isn't the sole actor in the problem of resistance. This graphic made by the CDC a decade ago outlines how the influence that antibiotics exert on the microbial world is due to hospital and community use, but also to massive agricultural use. And despite a reform movement that changed farming practices in Europe and then to some degree in the US, that remains a major stressor on the Gulf microbiomes of animals and on animal protein production and field crops. That's thanks to this gentleman, a British biologist named Thomas Jukes, who in 1948 conducted the first experiment, swiftly followed by a patent, that showed adding microdoses of chlortetracycline, the first tetracycline antibiotic, known as aureomycin, to animal feed could increase meat animals' growth and stave off diseases of crowding. And Jukes' discovery boosted that nascent industry of animal precision nutrition into becoming a massive user of antibiotics. And massive's not an overstatement. These are the most recent numbers. In the US, 24 million pounds a year in animals. Globally, almost 140 million pounds a year in animals. And it's crucial to stress almost none of this actually goes to cure infections, the reason we use antibiotics in humans. This is overwhelmingly prophylactic use, meaning that in the risk-benefit equation that we have to calculate every time we deploy antibiotics, the balance is tipped almost entirely toward risk. So just a couple more points. All of these influences, antibiotic use and overuse in healthcare, in community medicine, in agriculture, the profusion of antibiotics through the environment that I don't even have time to discuss, the emergence of parallel resistance in fungal organisms through broad use of crop-sparing fungicides. All of that has led to this. And this is an ugly, complicated slide because it's very hard to get all of the 20th century and the first quarter of the 21st century into one image. But this is the bug drug leapfrog. Pathogens catch up to the weapons that we deploy against them, and they catch up with increasing speed. For every new compound that's debuted, resistance has emerged to blunt its impact. And the result has been that since the beginning of the century, pharma companies have turned away from making antibiotics when we need them most. This graphic was made a decade ago for a path-breaking report sponsored by the British government, and it shows that it takes 10 to 15 years to get a new compound to market, and the amount of investment required, more than $1 billion. And they're considered simply not worth the spend by pharma companies who could be making safer, more profitable drugs like lifestyle drugs and cardiac drugs and diabetes drugs. Antibiotics, which are a crucial societal need, in business terms, have become an indefensible expense. And so most of the legacy pharma companies that arose at the dawn of the antibiotic era have simply exited the market. Only a few remain. And the small biotechs that are trying to take their place find they simply don't have the funding to get through what you're looking at that's called the valley of death between the end of NIH-sponsored preclinical funding and the beginning of earnings. The point at which a drug becomes profitable is only 2 years before a drug becomes generic. Since 2018, 6 small biotechs that had novel compounds that could have made a difference to clinical treatment have all dropped out, either gone bankrupt, removed themselves from the market, put themselves up for auction, and the IP that they were working on that could have made a difference has been shelved. So I'll leave us with this. This is a report that was released just last month by the World Health Organization. So many antibacterials in development, so many of them just Me Too drugs, a slight adornment on the molecule that they contain. Only 15 qualify as actual new modes of action. For 10 of these, it's not clear whether they will stimulate cross-resistance to other drugs. Only 5 of those 90 antibacterials are effective against at least one of the bacteria that the WHO considers most critical. At a point when resistance is cresting because of our inattentive behavior, the tools we need to combat it are in the shortest supply. And that's what I meant when I said we're at the inflection point of the tragedy, when the hero has the opportunity to continue down their destructive path or to change. And with that, and with apologies for my bad screen management, I'll turn this over to my colleagues and stop sharing.
Thank you so much, Myron. That was wonderful and somewhat shocking to me, who's been out of actual clinical practice for a while, but boy, that was something. So we're now going to turn this over to Majad, who will, oh, look at how quick she was. Whew. All right. Thank you, Majad. I don't have to say anything else.
Thank you. And thank you, Marion, for sharing kind of the story of the history of antimicrobial resistance. That was kind of interesting. I've never kind of heard it from that sense. So thank you for that. So my part is to kind of discuss the clinical consequences of antimicrobial resistance and really emphasizing on the impact on healthcare systems and patients. And I will illustrate this by using a couple of cases throughout this discussion. The objectives will be to describe the clinical consequences of antimicrobial resistance in different settings and to recognize the economic and human burden of resistance. So as Maren discussed, we are seeing rapid increases in the rate and number of infections caused by antimicrobial resistant organisms. This is from the CDC, and it shows the pathogens that they consider as urgent or serious threats for resistance, like carbapenem-resistant Enterobacterales, carbapenem-resistant Acinetobacter, Candida auris, for example, VRE, ESBLs. And you can see that all of these pathogens have increased from 2019 to 2022, with the exception of MRSA that remains stable. We know there's a global problem. We know there's a national problem, as you can see from this slide. But is there a problem in Massachusetts, or do we live in a bubble, in a haven without resistance? Unfortunately, we don't. So this is data from the Massachusetts Department of Public Health. And you can see that the carbapenemase producing organisms in Massachusetts, the number of infections and colonizations have increased by 30% between 2022 and 2023. And like Maren has mentioned, there are a lot of causes for resistance, but truly the most important modifiable risk factor for resistance is the use of antibiotics. So unnecessarily longer course of antibiotics can lead to resistance in individual patients and on a population level. So whenever you're prescribing antibiotic or when you see patients on antibiotics, you really want to ask yourself two questions. Are these antibiotics necessary? And am I giving the patient the shortest duration possible that will cure their infection? Now, I will blow your mind right now. Okay, one mind-blowing idea. Stopping antibiotic treatment early does not cause resistance. I don't know how many times I've heard it, from colleagues, from physicians, pharmacists, nurses, that if you are prescribed an antibiotic course for an infection, you have to finish it, or else the bacteria in your body will become resistant. That is true for some infections like endocarditis, but for most common infections like pneumonia, sinusitis, or otitis media, that's not true. If the patient is clinically better, choosing a shorter rather than a longer course of antibiotic is associated with fewer adverse events and less resistance. If you think about it, 10 years ago, we used to treat pneumonia for 14 days. Maybe 3 to 5 years ago, we started treating it for 7 days. Now we treat pneumonia for 5 days. And there's more data that show 3 days of antibiotics are enough to treat community-acquired pneumonia. So every day the patient receives beyond the 3 to 5 days is an extra day that they probably don't really need. So what are the clinical consequences in outpatient and chronic illness? I will share a case and we'll go through it. So this is a poll question, but unfortunately the poll is not working. So if you can put the answer in the chat. So you have a 65-year-old female with a history of heart transplant. So she's immunocompromised, overall sick. You're seeing her in your outpatient clinic. She's trying to establish primary care. When you evaluate the patient, she tells you her urine smells funny, but she denies dysuria, urgency, frequency, abdominal pain, or fever. She said this happened earlier in the year and she received antibiotics for it. And it helped with the urine smell. So what would you do next? Would you send a urine analysis with reflex to culture, send a urine culture alone given the patient's symptoms? Would you start empiric antibiotics without delay since she's immunocompromised? Or would you just reassure the patient that she's not at risk of UTIs because her urine odor is not a risk factor for UTI? Who can, oh, sorry, wait. Okay, so some people answered 1. Okay, so people are answering 1. So actually, the right answer is you can reassure her that she's not really at risk of UTI due to urine odor. We hear this all the time. and I know this is slightly off topic, but I wanted to include this slide, is that urine smell or odor is associated with infection. And someone did the study. They made 2 research assistants sniff the diapers of a freshly voided urine in a nursing facility, and they compared the results of the sniff test with the urine analysis and urine culture results. And they found that using a urine odor to identify a UTI resulted in error in 1/3 of cases. So there's really no association between urine odor and UTIs. And urine odor can change based on what we eat, based on whether we're dehydrated, for example, becomes a little bit more concentrated, based on medications, based on hygiene, but it's not associated with UTI. So unfortunately, the patient went to a different clinic a few days later, and she got a course of antibiotics. Outpatient antibiotics are a big problem. So over 80% of the antibiotics prescribed in the US are prescribed in the outpatient setting. And in 2024, about 255 million prescriptions were given at a rate of 752 prescriptions per 1,000 persons. So that's a huge number. And based on conservative estimates, about 28% of these antibiotics are actually considered unnecessary. You're seeing the patient again 4 months later, and she now has an urge to urinate every 30 minutes. She has burning sensation with urination, so symptoms of UTI. And she reports that now it's November, she had received 4 courses of antibiotics this year for foul-smelling urine. So you send a urine analysis with reflex to culture, and this is what you get. An ESBL E. coli that's unfortunately resistant to ciprofloxacin, levofloxacin, trimethoprim sulfa, and macrobid. So the patient had to be admitted to receive IV antibiotics for simple cystitis, and it's not an outcome we want for our patients. The implication of antibiotic resistance for common infection, we're seeing more and more resistance for these kind of common infections like UTIs, pneumonias. So for outpatient UTIs, the resistance rates among Enterobacterialis isolates is approximately 20% for trimethoprim sulfa, fluoroquinolones, and nitrofurantoin. And this is different across the nation. These are numbers from the whole US. Like, for example, at Tufts, we have slightly higher resistance to trimethoprim sulfa and fluoroquinolones, about 30%, and a little bit less for nitrofurantoin. ESBL producing isolates account for about 7 to 9% of all the isolates. And then multi-drug resistant organisms, and here they define them as being resistant to 2 or more classes of oral agents, are about 16 to 18%. This means that treating simple infection is a little bit trickier now because we're seeing more and more resistance to oral antibiotics. And we know that clinical failure is more commonly associated with antibiotic-resistant organisms. So this group looked at specifically antibiotic-resistant E. coli and strep pneumonia, and they found that patients who had UTIs with antibiotic-resistant E. coli were 4 times more likely to fail clinical treatment than those without resistance. And they also found that antibiotic-resistant Streptococcus pneumoniae had double the risk of clinical failure if they had a resistant pathogen. And the same with pneumonia. They had double the risk of failure if they have an antibiotic-resistant strep pneumo. And we know that the effective antibiotic is not transient. So it's not just while the patient is on the antibiotic course. The effective antibiotics on the development of resistance is greatest really in the first month, but also persists for up to 12 months after a course of antibiotic. I hear this all the time. I want to give patients antibiotics just to be on the safe side. I hear this, literally like every day. I don't think that my patient has an infection, but I just want to keep cefepime just in case. Is it truly the safer thing to do to give a patient antibiotic when they don't have an infection? I would argue it is definitely not. And there are many, many studies looking at this, whether it's increasing the risk of C. diff, the risk of adverse effects. And I want to share one study that's related to our patient, which is the treatment of asymptomatic bacteriuria. This is just one example from the literature where this group followed 673 women who were treated for asymptomatic bacteriuria, so patients with just positive urine culture. 360 were treated with antibiotics and 300 were not. And they followed them for a year. So at the 6-month mark, they saw that about 30% of the women who were treated for asymptomatic bacteriuria developed actual symptoms and symptomatic UTI, compared to only 7% of the patients who were not treated. So treating patients or treating really positive cultures, a red result in your EHR, doubled the risk of symptomatic UTI at 6 months. And at 12 months, almost 50% of the women who were treated developed symptomatic UTI, compared to 13% of the women who were not treated. So this group found that giving patients unnecessary antibiotics, treating their positive urine cultures, tripled their risk of symptomatic UTI, likely because we're disrupting the normal urogenital flora in these patients. And not only that, but we also found that the patients who were treated in Group B had higher rates of resistant E. coli to amoxicillin, clavulanic acid, trimethoprim sulfa, and ciprofloxacin. I'm going to shift gears a little bit to talk about the clinical consequences in cancer patients. This is a big topic. We can talk about it for hours, but I wanted to share a timeline of a patient who was just diagnosed with hematological malignancy. So you can imagine a 25-year-old man who just got the diagnosis of ALL, or acute lymphoblastic leukemia. And we'll see how resistance really impacts his course of treatment. So usually the treatment for this type of cancer is chemotherapy that often destroys our neutrophils and causes neutropenia. And typically we use fluoroquinolones, ciprofloxacin, and levofloxacin for prophylaxis to prevent serious infections. But because of the rising resistance to fluoroquinolones in the community, we find that fluoroquinolone prophylaxis is less and less effective. Patients, we see more breakthrough infections. So the patient comes in and he has a fever and neutropenia, so he has neutropenic fever. And typically in these patients, we give them an empiric antibiotic regimen until we really identify a bug that's causing the infection. But because of resistance, we're seeing decreased effectiveness of our empiric therapy. So for example, at Tufts, we use cefepime for neutropenic fever, but because of the rise in ESBL enterobacterales and carbapenem-resistant organisms, cefepime might not be effective in more patients today than it was even like a year or two ago. We also have a limited selection of targeted agents. Like Marian mentioned, we only have really a handful, like 2 or 3 antibiotics that work against CREs, that works against highly resistant Acinetobacter. So we're very limited sometimes with our antibiotic choices. And because we're giving patients very broad antimicrobials, we end up seeing breakthrough infections with bugs that are just indolent. We can't sterilize the body. We can't sterilize the environment. So when you're giving patients cefepime, meropenem, there are bacteria in our bodies that are naturally resistant to these antibiotics, like vancomycin-resistant Enterococcus, for example, and Stenotrophomonas. And even when this 25-year-old man is feeling better and he is ready to go home, we find that we're very limited by the selection of oral therapies. And this actually could potentially lead to prolonged hospital stays for these patients. And most importantly, probably the most important indirect impact on patients is that infections can lead to delays in chemotherapy and cancer-directed treatments like surgeries, for example. We don't do these things when patients have an active infection. So when the infection is more complex, we have resistant organisms, it could significantly delay life-saving therapies, chemotherapies, and cancer treatments. And lastly, I wanted to discuss the overall kind of big picture clinical and economic burdens of resistance. So we've talked about the impact of AMR when patients have resistant infections and the consequences of increased morbidity and mortality. And that's more specifically related to, basically, it makes everything worse. It increases all-cause mortality. It increases hospital length of stays, need for ICU care, time on vent, excess surgery, because they require, multiple debridements. And there's also all of this is associated with functional decline and need for post-acute care. There are massive economic burdens on the patients, and that's related to loss of work, loss of income, increased healthcare costs. So when a patient needs to stay in the hospital for 7 days instead of 2 days because they need, for example, IV antibiotics, that's added cost to the patient. What about the impact on the healthcare systems? So we know AMR increases resource utilization and cost. So a group in Iowa estimated that the healthcare cost related to AMR is about $4.6 billion per year. That's excess cost just because of antimicrobial resistant infections. There's increased strain on resources, so we need more ICU beds, increased rates of readmissions. I mean, even in Boston, there are probably in a 10-mile radius, there are, I don't know, like 5 hospitals, but patients are on waiting lists to get ICU beds. There's a need for isolation and infection control measures, and anyone who works in a hospital, LTAC, nursing, SNF, I mean, I'm sure you all have, like me, a love-hate relationship to isolation and contact precautions. I mean, they take extra time. They're very important for our patients, but they're also a drain on resources and they're costly. And lastly, diagnostic testing. So when we get resistant infections, we often need to do additional testing. So we have to send them to outside labs. That takes time and effort and money. Something we don't talk a lot about, which is the impact of AMR on patients without resistant infections. So all of us as users of the healthcare system, as patients, we might not have infections with resistant organisms, but we're also impacted by AMR. So we are exposed to MDR organism, multi-drug resistant organisms during routine care, like elective surgeries, as the rate of resistance increase in the healthcare system and in the environment, in the community. We're also exposed to broader antibiotics. So we have to sometimes overuse broader antibiotics in high resistance settings. And I'll give you one example. For the treatment of pneumonia, for community-acquired pneumonia, we used to use azithromycin or Z-Pak. But because the most common cause of pneumonia, which is Streptococcus pneumoniae, is becoming more and more resistant to azithromycin, in some settings, we don't recommend azithromycin as the first line of treatment anymore. We recommend broader agents like cefpiroxime, for example, or Augmentin, for example. So we are kind of indirectly, because of the rising rates of resistance, we are exposed to broader antibiotics. And lastly, caregiver fatigue is increased with AMR. So people who care for loved ones with infections related to AMR, they have to deal, like I mentioned, with IV lines. There's increased potentially loss of income because they have to take more PTO to take care of their loved ones who are in the hospital for longer, etc. And lastly, this is my last slide, I want to kind of emphasize on the human face of resistance. Whenever we talk about antimicrobial resistance, we always talk about treatment failures, longer hospital stays, costs to the healthcare system, costs to the patient, and all of that. But we forget about the psychological impact on the patients. So this is from a patient interviews who had infections with resistant organisms, and they talk a lot about anxiety because of the diagnosis, a feeling of social isolation. You can imagine when patients, when you're walking into a patient's room or when they see providers come in and they're wearing PPE, it creates a sense of social isolation. There's a lot of emotional distress. Patients report that they feel like they don't get enough information from providers. There's a lot of fear. There's stigma. They feel, dirty. They're worried about spreading the infection to their loved ones. Every now and then patients ask me, can I see my grandson? Is it safe? They're scared. They're exposing their loved ones to these like highly resistant infections. And I just wanted to include the link to the IDSA's website that highlights patient stories. So patients share how infections with antimicrobial resistant organisms impacted them, impacted their lives, their families. And it's interesting just to kind of keep that like human aspect in the conversation where we're talking about antimicrobial resistance and think about the true impact on patients' day-to-day living with these infections. And that's all I have. And I guess we'll do questions at the end.
Subani, thank you very, very much for a very engaging, clear, and concise presentation. And I'm just getting more and more anxious every time I hear about this, but it was quite nice. And we're going to take a quick 5-minute break, and we will be back here probably at 7:20, 7:21 at the latest, so that we can keep moving forward. All right? Thank you. Mary Lou, I think we're good to go.
Okay. So, thank you for having me tonight. This has been fabulous. And Maren and Maja, I loved your talks, and I hope I can do justice to mine as we go through this. Penny, I do want to say thank you for letting everybody know how long I've been in nursing. Um, I thought that was a very interesting way of introducing, but it gave me the opportunity actually to say the one of the reasons I've really gotten passionate about this topic is that the first 25 years of my career I spent at the Children's Hospital of Philadelphia. And 15 of those years, I was the director of infection prevention and control. And so, this topic really, the idea of antibiotic resistant infections in patients and patients that I was taking care of firsthand, and then in infection prevention and control, I really saw what an outbreak of a highly a resistant infection could do in a neonatal intensive care in a cardiac thoracic unit. You really see what the outcomes are. So thank you, Penny. That gave me the opportunity to say that. um, so I did have two polling questions, which I just want you to think about, so we don't have you don't have to put anything in the chat or anything, but I wanted to say, in terms of nursing, how confident do you feel in your role as a nurse contributing to antibiotic stewardship? So just kind of think about this for a minute. And what I'd like to even you to do is reflect on when you actually when we started this presentation a while ago and towards the end, is that confidence potentially increasing? Oftentimes we hear nurses say, antibiotic stewardship is really the purview of physicians because they're doing prescribing, and that is actually not true at all. Second question is, in your current setting, how often do nurses participate in decisions related to antibiotic therapy? And that could be doing anything from reviewing antibiotic indications to durations to reviewing microbiology culture results. So again, just kind of think about that. Is it routinely? Is it occasionally? Is it rarely? Is it never? Or is it not applicable to your setting? So most of my comments will actually be related to more the role of the nurse in the inpatient setting, except that nurses have a role across the continuum of care. So kind of keep that in mind. This is just a little recap of what we've talked about so far. So antimicrobial stewardship refers to the safe, responsible, and effective use of antibiotics, antifungals, and antiviral medications. So when we use the word antimicrobial, we're thinking antibiotics, antifungals, and antivirals. When we use the word antibiotic, stewardship, which is, I have a tendency to really look more so very specifically at antibiotic stewardship. We're really referring only to antibiotics. That seems, especially in the nursing world, to be a point of what is the difference. So that's what this is. It's a set of coordinated strategies, and it's really designed to optimize infection treatment while minimizing adverse events and limiting the emergence of resistance. So really, I like to use this little schematic on the right-hand side because it's really about getting the right infectious disease diagnosis, the right drugs to cover that, the right dose, the right duration, and the right route. So it really gives it a very kind of straightforward look at the words of antimicrobial resistance or antibiotic resistance. I've also found in working with staff nurses, especially, and student nurses, that this word antibiotic and antimicrobial stewardship is kind of heavy. And so we really try to say, what does that really mean? And it really is the safe and responsible and effective use of antibiotics. There's multiple nursing practices that many nurses are already doing. They just don't really see themselves in the domain of antibiotic stewardship, but it really is incredibly important in the world of antibiotic stewardship. I'm going to just look at 5 of these this evening and mention them. Each one of these topics is actually could have an hour or more unto itself. The first will look at strengthening infection prevention and control, evaluating penicillin allergies and promoting delabeling, optimizing diagnostic testing, which is referred to as diagnostic stewardship, ensure the safe antibiotic administration, monitoring, and timely review, and then educating patients, families, and staff, and promoting awareness of stewardship outcomes amongst one's colleagues. So let's take a look at strengthening infection prevention and control. This is probably the most familiar to nurses. And so with each of these slides, I've done on the left-hand side why it matters. On the right-hand side, what are some of the nursing actions that some of us are already doing every day embedded into our practices. But the long and the short of it is that if infections are prevented, then antibiotics are not needed at all. So the idea is to prevent something from occurring so that antibiotics don't have to be used. Vaccination is certainly one of the most powerful tools for preventing infections. So by stopping vaccine preventable disease before they start dramatically reduces the need for antibiotics and helps combat antibiotic resistance. Nursing on the right-hand side, many nurses will be incredibly familiar with these actions already. So it's ensuring rigorous hand hygiene compliance, proper use of personal protective equipment, which is gowns, gloves, masks, etc., consistent adherence to isolation precautions, and whether that be contact precautions, airborne precautions, whatever that may be. Monitoring catheter, central line, ventilator use, and ensuring prompt removal when it's no longer needed. So very often in many bedside nursing practices, in taking care of patients that have urinary catheters or central lines, very often in terms of daily assessment and need, it's the idea of, does this patient still need this Foley catheter? Does this patient still need this central line? So, and it can prompt the removal when it's no longer necessary. What we try to do is actually just add another question within that same context and say, does the patient still need antibiotics if they happen to be on them? So also ensure rigorous cleaning and equipment decontamination, assess and update immunization status during patient encounters, and educating patients and families about the benefits of vaccination. So again, strengthening infection prevention and control is probably one of the most important nursing actions in terms of preventing resistance. Second one is evaluating penicillin allergies and promoting delabeling. So why is this important? Incredibly so, 9 out of 10 people who report a penicillin allergy are not truly allergic. This results, so if this particular patient comes to your setting and they say, I have a penicillin allergy, if that patient has an infection, more than likely the treating of that will result in the use of broad spectrum antibiotics. So correctly identifying those who are not actually allergic can improve antibiotic prescribing, combat the risk of antibiotic resistance by allowing patients access to safer, less toxic antibiotics. So again, nursing is at the front line of very often of taking detailed histories. And so if a patient reports that they have a penicillin allergy, you want to take a very detailed penicillin allergy history with very specific questions. I just mentioned a few things here, which are symptoms, the timing, the severity, the treatment, but there's a great deal of literature in terms of just what goes into a detailed allergy history to rule out penicillin allergy. You might also advocate for penicillin allergy testing or oral challenge when appropriate, and then educating patients to discuss the broader benefits of delabeling. There's a really nice schematic that I like. It's especially when I teach this with students, that if anybody's interested in this particular area, that was in the Journal of Allergy just maybe 5 or 6 years ago, that puts it in very nice, a nice way. So first, it's the label acquisition. So 75% of penicillin allergy labels are acquired in childhood by the age of 3, and most of those labels are inaccurate. And unfortunately, those labels follow people throughout their lifetime in many, many circumstances. So it's not unusual for a patient, and I would see this certainly in the pediatric world, where you might have a 10, 12, 14-year-old child or young person, and their parent says they have a penicillin allergy. And then you start asking very specific questions, and it actually turns out that they may have been a year old, 2 years old, but with very vague symptoms, and the parents really don't remember the events of that particular time. So looking at those, most of those labels, as I said, are inaccurate. So this is just this notion of the acquisition of the label persists and grows in significance. And then what are the consequences? And which I mentioned, it's the pressure of prescribing second and third line antimicrobials and perhaps increased inappropriate antibiotic selection. And then, and you can read the rest of that list there. And then it's the idea of, so how do you go about testing and removing of unnecessary labels? Lots of literature that has been done at this point to look at multiple ways of doing this and really the positive impact on the patients as well as in reducing the use of unnecessary antibiotics. The third area is in optimizing diagnostic testing. So this is what we refer to as diagnostic stewardship. And Majad, thank you for mentioning this and for the sniff test and the smelly urine, because this is one of those areas that certainly throughout my career I've seen a lot of this as well. That there's unnecessary culturing that leads to potentially unnecessary treatment of patients over time. So why does it matter? Diagnostic stewardship promotes appropriate, timely testing, pathogen identification, and accurate, timely reporting of results to guide patient care. Accurate diagnosis is the foundation of effective infectious disease management, where pathogen identification facilitates targeted antibiotic therapy. Ordering appropriate diagnostic tests based on clinical indication is crucial for appropriate antibiotic prescribing. So you say, what can nurses do? And this is often one of those areas, especially in Jefferson, where we work a lot with the nurses in the critical care units around diagnostic stewardship and advocating for appropriate testing. It's really a matter of sometimes them saying, how do you bring this up to the prescribing physician who orders testing, and how do you actually feel comfortable questioning the need for that testing? And so sometimes we have to work more in that regard than the identification. So nurses need to advocate for appropriate testing, collect samples before starting antibiotics, use correct technique, labeling, and timing to avoid contamination or false results, ensure proper specimen collection, and collaborate with the team so that there's unnecessary cultures are not being sent, duplicate testings are not being sent, and that prompt reevaluation when tests aren't indicated. The next slide here is also, I think, just a really nice schematic around diagnostic stewardship, which is, again, in a nutshell, the right test for the right patient to prompt the right action. So within this realm of diagnostic stewardship, we've got three different areas. One is considered pre-analytical, which is when the test is being ordered and the specimens collection and being transported to the lab. And these are the areas where nurses can really have impact. Then the analytic phase is when the specimen for this purpose is, say, in the microbiology lab. So that's where the testing is being processed and performed. And then the last section is post-analytical, and this is where testing is getting reported. And so the clinician is testing decisions and interpretation. So very often nurses are, especially in the inpatient setting, might be the first person who is actually seeing those test results. So they really need to learn how to interpret those results and report those results to the care team as soon as they get them. So again, just another nice schematic that puts a diagnostic testing in a nutshell. The fourth action or place where nurses can be engaged is optimizing antibiotic administration, monitoring, and timely review. So here, nursing-led stewardship practices can really help prevent inappropriate use, reduce resistance, and improve patient outcomes. Nursing actions that go along with this are verifying antibiotic indications, dose, route, and timing prior to administration. Ensure cultures and relevant diagnostics are obtained before initiating therapy, monitoring for clinical response and adverse results, and also participation in antibiotic timeouts or daily reviews to assess ongoing need and optimizing therapy. So these are really two different things in practice sometimes. What is a timeout and what's daily assessment of need? So we often think of of antibiotic timeout assessments as a reevaluation of a patient's empiric antibiotic regime in 48 to 72 hours within the context of the patient's current condition. And why is that? So think of the patient that's coming into an emergency department, and their initial workup is done in the emergency department. And so decisions and clinical judgment is being made during that time to place patients on particular regimes of antibiotics. So they're often initiated with very limited information. So the more information that is available, including culture data, lab results, imaging, and pathology, which is usually within about 48 to 72 hours, is an incredibly good spot to actually say, all right, we have much more clinical data at this point. What is it that we need to do with this patient at this point? So things like, does the patient still have a valid indication for use of antibiotics? Do the empiric antibiotics match the suspected site of infection? If microdata is available, do the antibiotics provide appropriate coverage for the pathogens identified? Does coverage need to be broadened or narrowed based on the available information? Is the dose appropriate for the patient given indication and patient-specific factors such as renal function and weight? Is the route of therapy appropriate at this time? So it might be the patient is on IV therapy and can be switched to by mouth or PO. And then the duration, has the treatment duration been assigned? So this is a great time to really regroup. And within, as I said, within some of our ICUs, the nursing staff has really taken a very active role within these timeouts at this point in time. The daily assessment of need can be a little bit different. This is where during nursing reports, regardless of, say it's the morning, the evening, whenever that change of shift is, the daily assessment of need is, are antibiotics still required? So it's speaking up. Can they be stopped? Can they be narrowed? What is going on with the patient at this time? So it becomes a very active kind of questioning, just like along the lines of infection prevention and control, when a patient has a line in, whether it's a Foley or a central line, and one says, does this patient still need the Foley? Does this patient still need a central line? So it's being very active in speaking up and asking those questions to the care team. The fifth is educate parents, families, and staff, and to promote awareness. So nurses are often the key educator in clinical settings and can influence behavior around antibiotic use, infection prevention, and looking at cultures. It's stewardship culture. Nursing, great area for nurses to conduct education for patients and families, why antibiotics may or may not be needed, the importance of completing courses of treatment, and what are the infection prevention and control needs at transitions of care. The other thing is trying within any clinical setting to start having nursing create what I call a stewardship mindset, which is really thinking about this every day when you're caring for patients. And as I said, these comments are mostly associated with inpatient care at this point, but certainly is in outpatient care, long-term care, wherever patients are receiving care. One of the things that certainly I have learned over these years is as nursing gets more engaged and involved in antibiotic stewardship, that one has to really understand where they're working and what is the context. So on any given patient care unit in any given time, there's the context in which antibiotic stewardship is occurring. There's the culture of the unit itself. So there certainly have been times that, not recently, fortunately, but in my own career where I have been told by physicians that this is not within the realm of nursing. And so one has to kind of understand the culture of a unit or your area of practice. and also the competencies of the nursing staff themselves in which to do these particular actions. So it's really, these actions are not designed to replace this centralized antibiotic stewardship program in an organization, but to enhance all of the actions that are being taken by the antimicrobial stewardship team. So if you're a nurse, where do you begin? So the first thing is to advance knowledge. And so what I would say to any of the nurses here, if you haven't been engaged in antibiotic stewardship for a while, so go through all of the slides that all of the speakers have actually been provided to you. Read the references that are in this presentation and all of the presentations, and start to participate in additional educational opportunities. I congratulate you for being here tonight. So you really want to advance your antibiotic and antibiotic stewardship knowledge. Learn with others, start interprofessional antibiotic stewardship journal clubs or a lunch and learn in your practice setting. So the more you talk about it and you learn from each other, more creative questions can come up as well. Advocate for the adoption and evaluation of one nursing-driven antibiotic stewardship recommended action in your practice setting. Bedside nurses are incredibly well positioned to lead a lot of these areas, and certainly working with the interdisciplinary team to how best that can happen. And I also say, get to know the members of your organizational antibiotic stewardship team. So at Jefferson, we have an incredibly robust team. There is a nurse that's actually, I think there are 2 nurses that sit on the antibiotic stewardship committee at this point. So nursing is getting much more engaged in what the team is doing within the organization. And the team is actually getting much more engaged in what nurses also bring to the table. So in summary, nurse involvement doesn't happen in isolation. You need to be working with the entire team. For stewardship to be effective, structures must support nursing engagement, formal roles need to be defined, shared decision-making, and you need leadership buy-in as well. And I would just say, start somewhere, get involved. There's lots of work to be done, and thank you. So that I will stop. Oh, and there's the references. So I will stop sharing my screen.
Thank you, Mary Lou. That was amazing. And I am sure that Jefferson University and those involved in the stewardship recognize the role of nursing because of you. And that was a wonderful presentation. So Megan Davis, we'll turn it over to you now. And go ahead.
Great. Thank you. Tough act to follow.
I know. I was thinking that. Oh my Lord, you're the 4th presenter. I have never heard presentations like this. So, but I'm sure you're going to do a great job.
Well, let's get everybody warmed up a bit. I mean, I'm a little bit chilly because the temperature has been dropping over the last couple of days. You have a bar. It might be on the bottom. It might be on the side. It says react. I want you to give me a show of hands that you can actually see my slides in the proper mode, that there's not something else going on. So let me see some raised hands or show of hands. Okay, great. Awesome. Now you know where that react button is, because I might ask you a couple questions as we go. So I'm going to change us around quite a bit. I'm going to talk about antimicrobial resistance in animals. I actually did start as a practicing veterinarian in Pennsylvania, Mary Lou, and worked with PennVet and a number of others in the area. So what do animals have to do with antimicrobial resistance? Well, Marin set the stage really well by showing just how much, I mean, literally like tonnage of antibiotics are used in food-producing animals. But we also have companion animals to consider. So I have 2 sort of cases I'm going to talk about in just a moment, but I want you to know that these are not your classic like individual cases. I come from public health. And so these are population-based projects in which I'm kind of giving some examples. I also want to start with a land acknowledgement, since no matter where we are, we're on the contemporary traditional homelands of Indigenous peoples. So I'm going to take a One Health lens. And what One Health is really that interface of that human health or public health perspective animal health perspective, meaning thinking about the outcomes in the animals and thinking about our stewardship there and how we have clinical outcomes in animals. The environmental component that I will talk about, and then there is this plant piece, right? We heard a little bit about the use of fungicides and how that may be contributing to fungal resistance, but also we use antibiotics on some plants. But I'm not going to go into that in too much detail. To start with pets and the household, we're going to focus on that classic superbug, methicillin-resistant Staph aureus. You'll hear me call it MRSA. And MRSA is really important because Staph aureus itself is a COP. It's a colonizing opportunistic pathogen. It gets on us in our noses and moist skin sites, and it hangs out and it waits for that opportunity, that, razor blade cut or other scrape where it can invade and then cause sometimes very serious infection. And of course, with our MRSA, we also worry about many of these strains being multi-drug resistant. But what you may not recognize is that because Staph aureus is gram positive, it's got this little coat around it and protecting it. So it tends to hang out in the environment for a really long time, weeks, maybe months, without disinfection or cleaning. And when we've gone into homes and when others have gone into homes, you can find contamination rates on both sites that you touch, right? You think about the cleaning protocols in hospital, the little glow-in-the-dark things that let them know if you clean that site. This is not just those sites that you touch. This is also like the top of the fridge. And that's because we all carry our own little personal cloud and we kick dust up into the air and it settles back out. So you can find it even in sites that you might not touch often at all. And we worry about this because you might have someone represented by my little graphic on the left who is MRSA colonized or infected, and we treat that person. So they clear. So you see time is our x-axis. And so at the next time point, that person is negative. But they've shed MRSA into the environment. And over time, if it persists, which it often does, then they can reacquire that same MRSA from this environmental reservoir. So in a study we did with the University of Pennsylvania, actually, where they were looking at whether or not treating the whole household with a decolonization protocol, so chlorhexidine, body wash, and mupirocin nasal ointment, if that would improve the outcomes in terms of recurrence and time of until they were recolonized. And the spoiler alert is it didn't really help that much doing the whole family. But we found that the environments were really, really contaminated. And we looked at risk factors for multi-drug resistance. And I want to give a shout out to one of my students, Dr. John Shabazian, who really looked at these risk factors and identified that whether it was at enrollment, shown in the black bars, or 3 months later, so we were following these households over time, that there were quite a few sites that were contaminated with multi-drug resistant MRSA. And these risk factors included not just ongoing human use of antimicrobials in the household, but also pet use. And some of them were disinfectant resistant. And so we weirdly found that use of disinfectants that should work against MRSA actually was a risk factor for finding these more multi-drug resistant strains. And we found more of them in rural areas, and a lot of these were livestock dense areas. And so that's a possible mechanism there. And this was maybe particularly true in the bedroom. We also looked at pets and pet multi-drug resistant staph and MRSA outcomes and found a lot of the same risk factors that you would identify in people, whether they themselves are on antibiotics. And in this case, we found a particular association with clindamycin. And we were looking not just at Staph aureus, which actually only rarely causes problems in dogs and cats. Much more often, you find that there are other members of the genus. So Staph schleiferi or Staph pseudintermedius are the ones that tend to cause those, disease outcomes in dogs and cats. And I would say if you were taking like the SAT, right, there's that question, as MRSA is to people, so methicillin-resistant Staph pseudintermedius is to dogs, causing very similar clinical presentation in terms of the dermatologic outcomes. And so we see that a lot of these same risk factors apply. And if we were looking specifically at MRSA, we found that in general, the pets were carrying the strains that were in the environment. In fact, I don't think we had a single pet who was positive for MRSA colonization that wasn't in a household that had environmental contamination. And the reason for this makes sense because the pets aren't really a great reservoir for MRSA. They tend to pick up strains from humans. So the humans bring it into the house, and then sometimes the pets will get it. And sometimes, very rarely, they'll get disease from it. But much more often, they're both kind of being exposed in this shared environment, and animals may be much more closely engaging with the environment than most adult people will. And so you can see that the different kind of antibiograms was relatively similar, although there was a little bit of difference between what you saw in the pet and what you saw in the environment. So here's your question, show of hands. How many of you ask about household pet ownership as part of any history taking or think about it at all? Okay, I'm not seeing a lot of hands, but you may be struggling to get to the button, so I will not judge anyone. But I'll just say it may be an important thing to consider. The pearl here is that if there are recurrent cases, that not just focusing on the one index patient, but maybe considering we have limited evidence for the whole household, but I think that's because we never did anything about the environment. So if there's one thing I would change, I wouldn't necessarily treat a pet because many of them, if you clear the environment, can clear on their own. I would focus on the environment and environmental decontamination. Few thank yous to all of the team on the pet and environmental transmission of staph study, pets. And let's go on to food animals because that is a really important area. And here's where I have some good news. Right? There are some things that we can do. There are individual decisions we can make, and there are collective societal things that we can change. And they do hold some promise. So if we think about, and this was showing it from a bit of a microbiome or resistome perspective, where it's not just like the SCC mech in Staph aureus that makes it a MRSA, but that the genes themselves can also move through commensal organisms or other organisms, environmental organisms. They don't have to always be associated with a pathogen because bacteria, they can have some parties and they can exchange some of these trading cards for resistance. And so we really should think about both as being important. So if we are using antibiotics, for example, in a chicken house, and that's shown in the lower right-hand corner, then what are all those different pathways by which maybe a particular pathogen that's drug resistant, or more likely just an everyday bacteria that's hanging out in the chicken's gut is going to get into, for example, the field and into water sources and therefore into people, into the community or other animals, or through the food pathway. And so food is something that we've focused on a great deal in some of our work. And so when we've looked at organic versus conventional retail meats, and I really want to give a shout out to Dr. Gabriel Innes, who took the lead on a lot of this work in the National Antimicrobial Resistance Monitoring System database. We wanted to know if that consumer demand, if you choosing organic meant anything in terms of your exposure, and the answer is yes. One of the more interesting things that we found, however, was that not only did organic have a 66% lower prevalence of a multi-drug resistant organism being present on that piece of raw meat, but that going through going through a processing plant that did both conventional and organic, and therefore was required to clean between the conventional run and the organic run, actually improved what you saw compared to the conventional. So conventional going to conventional processing was the highest rate of multi-drug resistant organisms. Now it's tough for you as a consumer to figure that out. We have all sorts of databases and ways that we could do it. So in this case, I would say buying organic and also using really, really good food preparation hygiene is the way to go. Another interesting thing that we found is that retail meats, so this is like your chicken, your pork, your turkey that you're buying in the supermarket, the longer it had traveled, the more likely it was for us to find multi-drug resistant organisms on it. And so this might suggest that buying local could also potentially mean that the retail meats that you're buying could have a lower risk of carrying these drug resistant organisms. But one of the things that we did that I think is most interesting is we looked at California, and this also occurred in Maryland, where I'm currently from, and was born and raised in. But in California, where I trained as a veterinarian, they passed a law called SB 27, Senate Bill 27, that said, we're just going to get rid of over-the-counter sales of antibiotics, and we're going to put more restrictions on the usage in food-producing animals so that they are really more tailored to be more like a human prescription, right? And this is happening at the time that there are also some other changes that were occurring at the federal level that I'm going to loop back to. And what we saw is that when we looked at retail meat, we were looking at chicken, E. coli, was that California chicken, after this law, experienced a reduction in a lot of these penicillin-resistant E. coli, and that we did not really see that occur with the non-California chicken. So we were purchasing chicken all in California, but some of it had been grown and processed outside of California and brought in, so it wasn't impacted by the state law. So same consumer market, just these two different things. But what was really interesting, and so I know this is a little bit challenging to look at, but I'll say that the size of the circle is kind of the magnitude, and the blue is a decrease, and an orange is an increase. And so if you look across all of these different drug classes, you'll see that for a lot of them, like streptomycin, gentamicin, and a number of others, that we just saw widespread decreases regardless of whether they were in California. And part of this may be because at the federal level, there had been a big shift in how antibiotics were being placed in feed. Remember that aureomycin that Maren talked about that was put in the feed for growth promotion? Not only had some of those growth promotion uses been removed from the label claims, but in addition, there was something called the Veterinary Feed Directive Rule. And I'm going to try to make policy sound very, very cool for you. The VFD said, guess what? If you are a big grain company and you are making all of these premixes for everybody, you can't just do the shake and bake and just add the antibiotics and sell it. You actually have to have that person who's buying it, that farmer, give you the prescription from a veterinarian. And so that has really been a dramatic effect on the kind of usage that we've seen across the entirety of the United States. So what does this mean for people? Well, in some other studies that some of my colleagues, like Dr. Lance Price, have done, they've found that there are actually genes that you can sort of trace back to see, oh, is this E. coli actually of food animal origin? And they've linked that to human UTI cases. So we focus on human UTI cases, and we had to use a big database across a lot of different states in the US to do something called a synthetic control analysis. Okay, so for those of you who want to go read all the papers, this one I'm going to say the method section is really dense. So you may just want to skip that part if like math is not your thing. So what we do is we use really cool math to say, okay, here's what California looks like in terms of its trends in resistance. And so before January 1st, 2018, before that law went into effect, we're going to use all the other states and we're going to use math to create a synthetic California. And then we're going to compare that synthetic California after the law was passed to what we actually see. And what you see on this image is basically the difference in the resistance prevalence between real California and synthetic California. And so as you would expect, on the left-hand side of that dotted line, you see that they're pretty much tracking, right? There's a little bounciness, but it's mostly hovering around zero difference. And then after January 1st, 2018, after the law was passed, you see a big decrease in resistance to extended spectrum cephalosporins, strongly suggesting that the law actually did cause a benefit in terms of improvement in extended spectrum cephalosporin resistance in E. coli. Just going to note, don't go just blindly advocate for all states to pass a policy without kind of going through a real process. Because we also, as part of this, reached out and talked to producers, extension veterinarians, veterinarians in clinical practice, academic veterinarians. We talked to a whole bunch of people. And really, by and large, what we heard is that regulation, if it's not done well, if it's not part of a participatory approach where people have a chance to really think about, well, what are the unintended consequences, can often then end up being more problematic and can end up causing more problems than they necessarily solve. And that you have to think about all of these different agencies that work are also in these silos. And so that means that they're not really talking to each other. So policy can work. I would just argue that it needs to be done very carefully and with a lot of additional kind of feedback loops so that we can check and see, is it working? What are the harms it's causing? What are the benefits we're getting from it? How can we modify it as we move forward? And so with that, some thanks to the great Aries team. And we're now going to move into Q&A and discussion. So I am going to stop share and turn it back to our great leaders.
Okay, thank you very much, Megan. The one thing this made me think about, and it's very embarrassing, is that I am the worst at meat preparation. And I never even I'm just really bad. And now I have a very different perspective on all of this because of every one of the speakers. So I really thank all of you. And I guess what I will do is turn it over to the Q&A and let anybody put their questions in the chat. And if anything doesn't come up in the chat, I do have a few questions that I can pose. And I'm going to try and go back to my view, everybody. My view, and I'm going to put gallery, and there we are. We have tons of people here. This is really good. And Esme, do we have any questions yet?
Nothing so far.
Okay, so then I'm going to post my questions. Let me just think here because I was writing them down and it's kind of sloppy. Well, first of all, one comment, and that was that having heard these panelists, I'm now sure the participants can see why it was very difficult for me to shorten their introductions. They have been absolutely amazing. So I think it was Marin who talked about this. With few new antibiotics being developed, and anybody can answer this in case I'm wrong. With few new antibiotics being developed, what alternative strategies, such as vaccines, diagnostics, or infection control innovations, offer the most promise? And anyone can speak up.
I'll start just because you mentioned my name. I think Dr. Manning talked about this, I believe, but talked about how prevention is so important because then we don't misuse antibiotics. Well, vaccines, I think, are a key and underappreciated tool in the fight against antimicrobial resistance for the same reason. If a disease doesn't occur, you don't have to treat it with antibiotics. And so improving vaccination rates for some key diseases really could make a difference in the occurrence of those diseases and the need to treat them clinically when they occur. And beyond that, I'm not a clinician, so I'll let the others answer.
All righty.
I would just add something like quickly about kind of antibiotic development. It's always tricky, kind of like Dr. Manning, Mary Lou shared, is that We want the antibiotics, but we have a lot of stewardship initiatives because we don't want to use overly broad antibiotics. So pharma loses money. So like initiatives where, the government is subsidizing those pharmaceutical companies to have the antibiotic on hand, which is kind of what they've been doing in the past few years. So we have the antibiotic, but we don't want to overuse it. So those kind of are some of the mechanisms that have been used to kind of incentivize pharmaceuticals. But I wish I have more antibiotics, like broader antibiotics, just to have to keep, on hand. But it's kind of a difficult balance, and prevention is key, kind of like Maren and Mary Lou mentioned. I see a few questions about meat, and I kind of want to know the answer too. Um,
Yeah, I can jump in on that. There's a question about, hey, so I read an article that UTIs related to infected beef are a thing. Is this not a decrease? And there are a couple answers. The first is that sure, when we look at the big surveillance structure, which admittedly only looks at generally for food types, maybe fewer now in 2025 than, for example, in 2024. You do see overall some trends of decreasing resistance. And we've certainly then seen, in addition to that, that there are these additional components of organic or raised without antibiotics, label claims being associated with even lower trends, and that these are a bigger market share. So some of it's driven in part by the increase in the market share for how they're raised. I want to add a note though, because with beef, you think about E. coli 157H7 or 104H4, the ones that are also associated with like hemolytic uremic syndrome, very, very severe outcomes, especially in kids. And that we sometimes see that the E. coli's can be enriched in beef that are finished at kind of that big conventional feedlot where they're put on grains, it shifts their whole gut, and that can kind of lead to the shift that's in favor of some of these strains. So how you raise them is also critically important, not just whether you give them the antibiotics, but there are some pathogens to think about. So I wouldn't say carte blanche beef is great, right? And we're not talking about climate change either, but I'm not going to go down that wormhole.
All right, thank you. I'm seeing, let me see. What are your thoughts about imported? You sort of answered that. What are your thoughts about imported meats that are starting to show up at the meat counter?
Depends on the country, right? Every country is different, and globally, antibiotic use in animals is high when you're
Right.
talking about food producing animals. So it really does matter. And we have not specifically looked at imported meats in terms of the distance. We were only able to do that within our US based samples because of the surveillance program by the FDA that really kind of captures enough for us to be able to do that. So I don't know if the longer it travels, the more challenges we might have. And
if
there
I
are a
could,
lot of additional complicating factors. Yes, please jump in here.
well, if I could just reframe that from meat to protein, one of the things that we don't talk about a lot because it's not a production system that exists in the United States, but is only an import system, or rather, it is protein that is produced elsewhere and is only imported, is fin fish and seafood, particularly shrimp, which are farmed. That now, ocean-based salmon farming is not legal in the United States, but plenty of the salmon that we buy, for instance, in supermarkets, is raised in places that have high antibiotic use. And I personally am deeply concerned about imported shrimp and the amount of not just antibiotics, but also other toxic compounds that are used on them from time to time. When the FDA does testing on imported shrimp, the numbers are really startling. I don't know if that anybody's done beyond doing analyses for the presence of compounds, Megan. I don't know if anyone's done any work on like this potentially affecting resistance, but or ways in what. I'll just stop there with that. But I think that when you think about imported protein, it's important to think about seafood in particular.
Yeah, I completely agree. I'll find some fun things and put them in the chat for those who want more reading.
Okay, we do have a question here. I believe this is probably from Mary Lou. Are there negatives around a timeout antibiotic assessment, i.e., progression to sepsis? Can a delay be dangerous, and how is this assessed in a quick enough way?
Well, I think the idea is to do the assessment, and that doesn't mean in that assessment one will change the antibiotics that a patient is on. So part of it is just going through a very specific series of questions that are in that's one slide that had all of those
Right.
questions related. So yes, the one doesn't want to be taking patients off of antibiotics that they need for an ongoing infection.
Okay, and so have you ever seen that the timeout antibiotic assessment impacts what happens? Like, in other words, like it takes too long and it should have happened sooner.
The assessment, I'm not
Yeah,
exactly.
the assessment. You'd encourage that the assessment occur pretty early on in the patient's admission and leave it at that.
Right. So one of the things that I've certainly seen and in clinical practice is that when one patients can be, especially patients that have come through the emergency department, if people don't actively ask those questions, there are patients that are on unnecessarily antibiotics for long periods of time. So the idea is that there has to be a very active, intentional way of doing this as opposed to not doing it at all.
Okay.
Amaja, would you say that's correct?
Yeah, I completely agree. And I think especially nurses, because they're at the bedside much more than any other person, participating in the patient's care. They know, for example, if the patient's doing better, I mean, they can, mention that potentially, or they know if the patient is able to take PO. So they could potentially kind of switch the antibiotic from IV to PO. And we have, there are nursing kind of driven protocols to do that in some institutions. So I totally agree that, assessment, daily assessment, or at least every other day is really crucial, because you don't want to keep the antibiotic on 30 days of ciprofloxacin for the unknown.
Wow. All right. Thank you. I'm looking for other questions, but I don't see one, so I get to ask another. This was for, I believe, Megan. Should, and this is really down to earth, should hospitals still be testing for MRSA before surgery?
Oh, I should probably turf this to my human clinicians because I do not do human clinical care. I will say that there are a number of different interventions that can be done to help reduce skin carriage, including use of chlorhexidine or dilute bleach. And that's something that we also think about on the veterinary side with our other methicillin-resistant staphylococci. So let me turn it over to a physician.
Like how about Mary Manning or Majad?
Majad, I'm gonna turf that to
I was
Majad.
going to say Mashad.
No, I think your infection prevention,
Thank you,
it
Mary
depends.
Lou.
I think, honestly, like MRSA testing is very intensive. Like you need to have someone to get the test done, someone to follow up on the result before the surgery. So some institution, actually like mine, we do just decolonization for everyone. Just we assume everyone has MRSA, and we just give them the chlorhexidine washes, the mupirocin before surgery. So that's like an example of broad spectrum exposure to broad spectrum antibiotics just because there's MRSA in the environment. But yeah, we do it basically for everyone. Just honestly, logistical challenges with getting the test done and follow up.
So
Yeah.
I would see that as part of antimicrobial stewardship, just doing that so that you don't have to use it, or that you're protecting the individual against it, and you're protecting against resistance
Yeah, I mean, the risk
developing.
is high enough that it kind of justifies doing it for everyone. But yeah, it's I wish we can like individualize medicine a little bit better, but it's It's the real world.
Yes.
All right. I think I have another question here. How much of a role does antibiotic route play in terms of developing antibiotic resistance? In other words, same drug and dosage, but given IV versus PO. I give that to anybody. I don't know whether that's Mary Lou or Majad, or do we have an answer? Maybe we don't. Maybe it doesn't matter.
I don't necessarily know if there's like a clear answer, to be honest. I think I'm not sure, probably not, as long as it's kind of gets into an effective level at the site of infection. We always like to use the gut if it's functional because there's less complication with an IV line, the risk of clots, risk of infection of the IV. It's more time like that you have to prep the drug, give it to the patient. So it's like an oral drug is a lot easier, but I'm not aware of like a specific study that looked at this question. It's a very good question. But I don't know if anyone else knows. Like,
Yeah, I can't say that that will be a question I will look up. But really, when you think of anybody with an indwelling line, there are complications and adverse events that can happen. So whether it's infection at the site of a line, whether it's infiltration, whether there's so many other kinds of things that can happen. So what you want to do is get any kind of invasive lines out of a patient as soon as humanly possible.
All right.
And I'll just
Thank
add,
you,
it's a
Mary
weird
Lou.
answer for livestock. So the weird answer for livestock is that because we do so much where we deliver it to the entire herd, that moving away from that and towards more individual animal treatment or small cohorts rather than the entire herd or flock or school of fish is what we prefer because of the level of environmental contamination and just literally the number of pounds that we're using across like 500, 1,000, 3,000, 100,000 animals is quite high.
That statistic was quite inspiring. Let me just ask you one other question, or I want to just make one other statement. First of all, a thank you because you all have been amazing. The second, or the comment I want to make is that given my age, you now have opportunities for hospitalization over time, and I did acquire pneumonia. And I live on the Cape in Massachusetts, which is not known for having like the best hospitals, like Boston does. But I was admitted for pneumonia, and I guess I feel more encouraged now that they did admit me for pneumonia, but it was only for 3 days. I was discharged on the third day. I did have IV antibiotics, and I honestly can't remember which one, but I didn't go home on anything. And that, to me, seems like there was a little bit of antibiotic stewardship there, because they didn't send me home on any oral antibiotics.
That's good, and you're doing fine.
Yeah, I'm doing fine, and I came home fine.
I'm sorry you had that hospitalization, but I'm glad you're feeling better.
So that was good. And I really want to thank you all very much. The presentations were very engaging, and I learned a lot, and I'm sure did others. And we're already getting comments coming in about excellent, knowledgeable speakers, etc. And I cannot wait to read the evaluations from this presentation. So with that, I guess I'll have Asmay go ahead and put up the link for oh, she did already. She's so good. And our speakers can actually now depart for the evening. And thank you very, very much for giving of your time. And everyone does need to know they literally give their time to this. And oh, I did have one other question. I knew it. And this is actually for Marin. Um, yes, you are one individual out there, very articulate, communicating to everyone. But what is our best? That's only one person. what is our best way as nurses or the lay public to communicate the knowledge we gained tonight?
So when I look at the history of how people have, how the public has absorbed the knowledge of the emergence of antibiotic resistance, I'm going to talk particularly about antibiotic use in agriculture because that is the subject of my last book, and it's the literature I sort of know the most, I've been in the most recently. It is really extraordinary how frequently in that history consumers expressing their opinion actually made a difference. Mm-hmm. In the 1960s, there was this sort of lost episode, historical episode, which was lost until I uncovered it, that there was a practice called acronizing, which was a practice invented by the pharma companies that created growth promotion to dip freshly butchered chicken and fish in a solution of antibiotic and then package it for sale. And like a lot of things in the post-war era, this started out with good intentions. The point was to attempt to retard the growth of spoilage bacteria on the surface of fresh meat, so it wouldn't be wasted. It could be held in a cold case at a butcher for longer, or put on a cheaper form of transportation that would take longer. But in fact, it was linked to outbreaks of significant skin and soft tissue infection among slaughterhouse workers. When you go back in grocery ads from the 1960s, you can see that local groceries were advertising acronized chicken, which was pushed by a big Madison Avenue style advertising campaign. And then public opinion starts to shift. And in small local newspapers, there are multiple letters to the editor saying, why doesn't our chicken taste the way it used to? What is this acronizing? What are they selling us? And this was happening at a moment when there were a lot of concerns about food supplementation and food additives in American society. And as a result of that consumer pressure, acronizing essentially went away by about 1968. The FDA responded to consumer pressure and withdrew the license it had granted for this practice. And similarly, about 10 years ago, when there was a reform movement for to get growth promotion out of American practices, prophylactic use, I think Megan can address that better than me. It's still going on. Both the Obama administration managed to create some controls in FDA regulation against growth promotion antibiotic use, and several major, this started with poultry, several major chicken companies, but one in particular, led in particular by Purdue Chicken, backed away from antibiotic use. And my belief is that both of those happened because of both in the political sense and in the commercial sense, they knew there was a friendly consumer movement waiting for them. Large buyers like medical centers and school districts had announced they were no longer going to buy meat raised with routine antibiotic use. When Purdue decided they were going antibiotic free, their CEO told me they were receiving 3,000 consumer comments a month asking them why they were still using antibiotics in their chicken. So this is a very long way of answering your question to say, I think that consumer voices really matter. And I think that people speaking up to their neighbors on social media, at the like customer service desk of their supermarket, to express their preferences and express what knowledge they've gained, I think that really makes a difference. And I would encourage people to do that more.
All right. And thank you, Maren. We'll end on that note. That's a very positive note. And I want to thank all four panelists for their incredible presentations. And I want to thank Harvard Pilgrim Health, who actually collaborates with us in doing these panels. And I will now let you all go, really. And I just wait the evaluations, and thank you very much.
Thank you.
Right.